Hi everyone, my name's Anisha and this is Bourann and Ankit. Welcome to another episode of The Heart of the Matter. Today we're going to be talking about the Smart Choice 3 trial. So I'm just going to give a brief intro before Bourann and Ankit kind of dive into it a little bit more in the next few parts. So basically, since the development and adoption of drug-eluting stents, there's been a lot of studies that have explored strategies for DAPT, particularly the first year after a PCI or percutaneous coronary intervention. Um, Basically, the long-term maintenance of antiplatelet therapy after the initial phase of DAPT, they think that that is actually really crucial, or the cardiology community has decided that this is crucial for lifelong management of patients who undergo these PCIs. The standard practice has been so far to recommend indefinite aspirin therapy, monotherapy after the 1 year DAPT for the prevention of subsequent cardiovascular events for patients who've had a PCI. So this was based on a meta-analysis that was done in 2009 in which aspirin was associated with a 12% reduction in serious vascular events compared with the control. So now, data supporting the use of aspirin as a single antiplatelet therapy after DAPT has been debated. So now everyone has been proposing, or it started to be proposed, that clopidogrel has been proposed as a possible superior alternative, especially as noted in the 2024 European Society of Cardiology guidelines for the management of chronic coronary syndromes. So this trial, the Smart Choice 3 trial, was specifically conducted to ascertain the efficacy and the safety of clopidogrel, compared with the aspirin monotherapy, beyond the standard duration of DAPT, which is the 1 year that we all know, after PCI. So specifically, though, what makes this study unique, it was kind of done after what the host exam trial. So this study specifically targeted high risk patients with a higher risk profile in general. And they also had, they wanted to really provide more stronger evidence so that we could really use this and extrapolate it to a bigger, wider patient population, because the host exam trial had some less strict endpoints. And I think that they wanted to rebuild the study and make it and have stricter endpoints, which my colleagues are going to talk about next. So, Ankit, do you want to talk a little bit about the methods?
Yeah, sure. So Smart Choice 3 was a multi-center prospective randomized open label trial that was conducted primarily in South Korea. So the included patients were 19 or older, average age was about 65-ish, at least median age, who had underwent a PCI with a drug-eluting stent, received standard duration for DAPT for their specific coronary syndrome, so 12 months at least for MI or 6 months for any other event requiring a PCI, had no cardiovascular events after PCI, and then had at least one complex coronary artery lesion characteristic or a clinical characteristic that was associated with a high risk of recurrent ischemic events, which included previous MI or medication related or treated diabetes. So to go into some of the complex coronary artery lesions that they identified in this study, it included true bifurcation lesions, CTOs, unprotected left main disease, a long coronary artery lesions, multivessel PCI, a lesion requiring multiple stents, at least 3 stents, and then ISR, severely calcified lesions, and then osteal lesions of a major epicardial coronary artery. The exclusion criteria was minimal, but also thorough. Included any pa or excluded any patient that required long-term oral anticoagulation, use of DAP for any other reason other than just CAD, or the use of single antiplatelet therapy at initial screening, and then any other contraindications to aspirin or Plavix. So 500 or 5,506 patients were randomized 1-to-1 to Plavix and aspirin. And then when they were randomized, they were immediately changed from DAP to single antiplatelet therapy. The dose of Plavix was 75 milligrams daily versus aspirin, which was 100 milligrams daily. And then in both groups, 2,722 patients completed at least 1 year of follow-up. A couple of things that were important to note. So while we're on the topic of follow-up, the median follow-up for the total population was about 2.3 years. And then a couple of things when we were reviewing some of the baseline characteristics, only 20 or less than 20% females were included in the total population in both groups. And there was an even distribution in between all coronary syndromes between the two groups as well. So I'll pass it along to Buran to talk about the results.
Yeah. So, the primary endpoint of this study, which was a composite of all-cause death, MI, or stroke, um, occurred in 4.4% of patients on the clopidogrel monotherapy versus 6.6% of patients on aspirin monotherapy, which leads us to an absolute risk reduction of 2.2%. This was a clinically significant find or statistically significant finding, I should say. And so there was a 29% lower likelihood of the primary endpoint occurring in the clopidogrel group versus the aspirin group. And then that leads us to a number needed to treat of 45, which is actually pretty good. Now, when we break it down further into what's driving this primary endpoint to be seen at a lower degree in the clopidogrel group, was a greater reduction in MI in the clopidogrel group, as well as all-cause death. And there was a benefit that was seen primarily in patients who had PCI for non-MI reasons. So presumably patients who had like stable or unstable angina or something to that effect. Now, when we separate it out into things like stroke, there actually was no significant difference between the two groups. And then with regards to major bleeding events, because this is, something we can talk about in the discussion, but that's of course an important consideration when we are talking about ADAPT or monotherapy with antiplatelets. There was actually no significant difference in major bleeding events between the Plavix or aspirin monotherapy group going on. So, in summation, there was a benefit to being on the clopidogrel monotherapy without an added risk, it appears, in this group of increased bleeding events versus aspirin. And so we can kind of start, discussing some of the interesting points about this study, and I think what they can do in future studies to address some of these things. So, as they mentioned earlier, I think Anisha was mentioning in the beginning, this was a study that was done in South Korea, and all of the patients in the study were South Korean. So it was a homogenous population. And then Ankit also mentioned that there was not very many women in the study. I believe we said it was less than 20%, and that was in both the clopidogrel and the aspirin groups. So it doesn't examine, we can't, necessarily extrapolate these findings to female patients, but also patients of other racial or ethnic groups. And the reason this is relevant, and this is something we can talk about more, is that in South Korea, and it seems like in probably East Asian populations in general, they have a higher prevalence of patients who have poor metabolism of their CYP2C19. And so because clopidogrel is one of those medications, and a lot of medications are metabolized through these cytochromes, but specifically because clopidogrel is metabolized through the CYP2C19 into an active form of the medication, since it is like a prodrug. The idea is that these patients theoretically don't get the full effect of clopidogrel, therefore they're at higher risk for thrombotic events and subsequently major adverse cardiovascular events. And then presumably there is a lesser risk for bleeding in that population in general if they're not getting the full effect of the clopidogrel. And so, this is like, for this population, I say this is pretty convincing. But because we know that generally speaking, we don't have the same genetic variant in other populations, I think it would be interesting to see how that affects it. And I think that's specifically why they studied it in their own population, because they know that this genetic variant exists. The other thing I think that's interesting is that the benefit that they saw in major adverse cardiovascular events slash MI was primarily seen in patients who were on the DAPT and then monotherapy following for non-MI reasons. So again, like angina, whether that's stable or unstable angina or whatever other reasons they might have had to cath these patients. And so while the point of this study specifically was kind of driven by the host exam where we looked at like lower risk post PCI patients and these were higher risk post PCI patients. It seems like still with that being said, the ones that presented with MI don't seem to have the same benefit that we saw with the patients who were presenting for other reasons. Um, but I have more things to say, but I want you guys to tell me what you think, and if you have any other thoughts.
Yeah, I mean, I think the SIP 2C19, the loss of function allele that exists, is I think one of the most interesting things about it, and was also brought up in the discussion of this at the American College of Cardiology conference. Ankit and I were both there as well when they discussed this trial. And I think it's fascinating that we have less GI bleeds. There's been other, or GI bleeding in general. But in other studies, what they actually said about South Korean and East Asian populations, they do a lot of studies in South Korea, so we can extrapolate that to other East Asian populations who have this loss of function allele, but that they also actually had less efficacy post MI. So this study is obviously not showing that. Um, it's obviously showing that it is effective, but only in patients who didn't have an MI. So I guess all of that combined, are we actually seeing a benefit in patients that have had an MI if we have previous studies that show that this didn't have a benefit in a patients that had an MI? And or are we just seeing the, lack of adverse events because we have decreased bleeding events or decreased metabolism, and
Mhm.
that's why we're seeing what we're seeing. I think that's the crux of this. And I think that's what makes it, as Bourann said, difficult to extrapolate to patients that do not have this SIP 2C19 loss of function allele. Ankit, I think that you also looked into this a little bit more, right? And they had done a little bit of subgroup testing. Do you want to talk about that?
Yeah, yeah. To both of your guys' point, I think the CYP2 C19 thing is actually very interesting. So, in this study in the appendix, they actually did do a breakdown between patients that were normal or like not normal metabolizers of Plavix, and they basically saw that there was no difference, which is actually kind of interesting. However, this was primarily done in like MACE, so it wasn't broken down into all this secondary endpoints. I think when we were there, Anisha, I think they were talking about publishing a another study about some of these exploratory endpoints with this cytochrome testing specifically. So I think that's something to look forward to.
I mean, I think the point of this study was to make it so that it's extrapolatable to, it's like, to broader populations. So they seem really dedicated to that, and they seem like they're continuing, like you said, the investigations so that it can continue, so that it can be more applicable. Bourann, did you have something else to mention?
I think the other thing which you kind of touched on right now was just that they are extending follow-up in this study, so we will actually get to see like true long-term benefit because the median follow-up for this study was 2.3 years, which is significant, but it would be interesting to see like 5, 10 years out how this affects outcomes for patients, particularly bleeding events, because I mean the standard of therapy, of course, is to do aspirin monotherapy. So we have really good data on how patients do with that, generally speaking, long term, but we don't have a lot of long-term data on clopidogrel monotherapy in post-PCI patients. So since this is ongoing, there will be like data for 5 years out, 10 years out that we'll be able to see that I think will be interesting.
Maybe we'll be able to do a part two in coming years, discussing this, talking about one of our, for not first episodes, but in the early days. Um, Ankit, anything to add?
The only thing I have to add, and as we know, and I think we've mentioned this before a couple times too, how like inflammatory like
Mhm.
syndromes are important in the development of atherosclerotic disease. So I was looking it up, and even the authors mention it a little bit too. So clopidogrel actually has some anti-inflammatory effects. It inhibits like leukocyte platelet interactions, which I just thought was cool, and I think it was something to mention.
Yeah, and I think that's also, I mean, I know that's why there's been a lot of investigation around colchicine too, right? Because of the that's why they've been trying to continue to pursue it for coronary artery disease. But it's cool that clopidogrel also has this, not the same, but similar anti-inflammatory effects. Um, okay, today we're gonna talk about what's your favorite season and why. Uh, Ankit, do you want to go first?
Um, so I'm from Texas, so I think for me it's gonna be summer when I'm able to go outside and go in the pool and whatnot. Moving up here was a big culture shock just because it is much colder and it's like very, very depressing half the year. But the rest of the other 6 months are wonderful. I can't, honestly probably even beats Texas, so can't
Oh,
complain.
that's fair. Veron, do you want to go next?
Yeah. So my favorite season my whole life has been fall, but just to preface, it's like Florida fall because I'm from Florida, which is not like the fall here. We're in Michigan, if for people who don't know that. But Florida fall is like summer, but just like a little less hot. So it's not real fall. I do love the fall here though, and that probably is my favorite. Well, summer here is my favorite season because it takes so long to get there. Like it's the middle of April now and it's still cold. So
It's like
anyway,
medicine, delayed gratification,
that
right?
was yeah, it makes you appreciate summer more. I appreciate it more now than I did when I lived in Florida for sure.
Yeah, sure.
For sure.
But anyway, that was very long-winded.
Do
Anisha,
they have leaves in Florida?
we have leaves, yeah. We
Do
do.
they fall during the fall?
No offense to any of
No.
our Floridian
That's really
followers.
crazy. Do we have leaves in Florida? Yes, we have trees, Anka. We have
My favorite season is
foliage.
spring. I'm just detracting from this. My favorite season is spring, not to be different from either of these two, but I just love seeing like all the plants and all the trees kind of blooming after winter. I think it's really beautiful. I went to IU for undergrad and it was just so beautiful in the springtime. Especially, I mean, fall is really beautiful as well, but they used to just plant like tons of flowers and all of the trees would be blooming and it was just lovely to walk around campus. And I'm a Midwest girl, so I grew up in the Midwest. So again, I wait for my spring, wait for the rain and all of the greenery to pop up. So it's just like a little bit less hot and there's a little bit of rain and I don't know, it's nice. So that's my favorite. All right. Well, it was a pleasure, everybody. We will see you next time. Thanks for watching. Bye.
Thanks, guys.